Good evening, everybody. Thank you very much for attending this webinar. My name is Niels. I'm a gastrointestinal and liver surgeon working in Amsterdam, and together with Andreas Brandl from Heidelberg and Helen Mohan from Sydney, I'll moderate this session, which is organized by the Colorectal group and Peritoneal surface malignancy group of ESSO. And we're really honored to have two giants in the field of peritoneal metastases. First of all, Alvaro Arjona-Sanchez, who works in Cordoba in Spain, will tell us everything about prevention of peritoneal metastases. And then Andreas Hingh from Eindhoven in the Netherlands will tell us how we should treat those metastases when they're actually there. So let's start, Alvaro. The floor is yours.
Okay, thank you so much, Niels, for your kindly presentation. Thank you so much for Andreas and Helen to invite me for this fantastic meeting, this fantastic issue for the webinar. I'm going to share my screen. Do you watch it?
Yes.
Okay, thank you. I'm going to talk about a very important issue, that is the prophylaxis of the peritoneal carcinomatosis in colorectal cancer. Sometimes our grandma say us always that prevent is better than cure in all the situations of the life. I'm going to present a very typical case for we can find in our daily clinical practice. This is a male, 75 years old, with high blood pressure, diabetes, CROs, BMI of 28. He was diagnosed by imaging, by CT scan. It was diagnosed by clinical T4 colon cancer. He was some enlarged lymph node, less than 3, and the clinical staging for this patient was T4 and to M0. And the pathology report about the colonoscopy was poorly differentiated adenocarcinoma with focal mucinous differentiation. The patient was presented on the NDT committee, and the decision was primary surgical management associating with HIPEC, because after our trial in our center, we performing HIPEC for this patient. This is the CT scan. You can see here that's how the right colon cancer is infiltrating the peritoneum, and this infiltrating is suspicious of infiltration of the muscle of the abdominal wall. This is the vision by laparoscopic approach. You can see here that this is the gross mass that this is infiltrating clearly the peritoneum and clearly the abdominal wall. We performed during the surgery, we performed a D3 right colectomy by laparoscopic approach, and we performed a limited peritonectomy and with excision of the muscle infiltrated by the mass by laparoscopic approach, achieving a complete cyto reduction for the patient. The definitive pathology was pathological T4B with N0. No lymph node infiltrated was observed, and we administered the HIPEC T4 protocol during the same procedure with metomycin C during 60 minutes by laparoscopic approach through the port of the laparoscopy. The patient was discharged with morbidity on day 3. He will start chemo. I think 4 weeks later. He has scheduled the chemo for the next week. Okay, on the background, we know we are here because the T4 is a very special condition on the colon cancer. And this is recognized as a risk condition for the metachronous peritoneal carcinomatosis. It is a very special condition of the colon cancer. For this fact, we have a special meeting in T4 colon cancer this year in Bruges. It was led by Andreas. We discussed a lot of things about the T4 colon cancer, about the prevention, about the management, about the chemo, about the radiology diagnosis before the treatment. This is a very important condition in colon cancer. And then some strategy in order to prevent the recurrence after treatment for this condition is the systemic treatment, has the adjuvant chemo or maybe neoadjuvant chemotherapy could have some benefit on this prevention. Another strategy has second look surgeries or one-stage prophylactic HIPEC with oxaliplatin has failed to demonstrate improvement in the local regional control disease. According to the adjuvant chemo, there is some controversial about the benefit in only stage 2 colon cancer, in high-risk stage 2 colon cancer, about the use of the FOLFOX for this patient. That the FOLFOX could be used in order to reduce the recurrence on this special staging patient. The MOSAIC trial demonstrates some benefit, but with the use of 444, but the author said that these results have to be cautiously assumed. Another trial was the SAKURA trial and did not show any benefit on the recurrent-free survival when the stage 2 colon cancer was treated by adjuvant chemo. And then the adjuvant chemotherapy is controversial for stage 2, not for stage 3. For stage 3, it is obvious, but for stage 2, well, there is some controversial, but it is clinically accepted to administer in high risk condition, has the T4 colon cancer. Another strategy, this is the most promising this year, this has been published this year, Foxtrot, but we have this trial, this is the Equinox trial that did not improve the recurrent-free survival with the use of FOLFOX. There were very few patients for this trial, and also we have a number very important. That is this percentage. This percentage I will be used this percentage during my presentation. On this Equinox trial, we have 33% of the patients were overtreated, were estimated to be overtreated by this prophylactic approach. If we take, all of us know about the recently published Foxtrot trial, and this is a very nice trial. We can see here that the use of the FOLFOX could prevent the recurrence at 2 years in the patient that received the neoadjuvant chemo with FOLFOX. But this patient, the estimated this overtreated population on this patient, instead of a specific teaching of the radiologist in order to detect the T4, but the estimated overtreated patient was 24% of the patient were overtreated on this trial. But the neoadjuvant chemo could be a very promising strategy for this patient. If we go to the HIPEC, to the HIPEC, we have some trial how the prophylactic. All of us know about the prophylactic is to perform a systematic second look surgery for this high-risk condition patient after a primary surgery and after adjuvant chemo, and the patient don't have any evidence of the disease. And then the patient was randomized to a second look surgery and HIPEC for the experimental group. This proactive and aggressive approach did not show any benefit on the disease-free survival for the patient, and also in an exploratory analysis about another endpoint, has the peritoneal recurrent-free survival. The second look surgery and HIPEC did not improve the benefit for this patient. This is another point very important that I'm going to repeat in my slide. Is the morbidity. The morbidity, we have to take in our mind two things. One thing is the population that we will overtreat it, and the morbidity that we are going to do with a prophylaxis. Then, because we are in a prophylactic setting, we are in a prophylactic context, And then on prophylaxis, you can see here that the major postoperative complication on the experimental group was up to 40% of the patient. Then on this trial, the endpoint was negative, but we have severe morbidity, and it could not be acceptable in a prophylactic setting in patients that we don't have evidence of any disease. Another strategy is to administer HIPEC during the surgery or early stage HIPEC, like the Colorectal trial. The Colorectal trial, the population was very similar on the HIPEC T4, is a population with T4 colon cancer or perforated colon cancer. And the experimental group was treated by adjuvant chemo HIPEC and after systemic chemo. The 18 months after the treatment, the patient undergone to the laparoscopy in order to discover early peritoneal disease. But for this protocol, only 65% of the patient received the complete protocol for that. The primary endpoint was the peritoneal metastasis-free survival, and this proactive approach, this use of the HIPEC with oxaliplatin during 30 minutes did not improve the peritoneal-free survival on this patient. Also, recently have been published an up-to-date for this trial in Journal Clinical Oncology, and the long-term follow-up for this patient did not show the benefit on the peritoneal-free survival. But it was no HIPEC. The problem, I think that the problem was oxaliplatin during 30 minutes. As I referred before, the morbidity, we have to see the morbidity on this patient. We had to see that here the morbidity was not so high, and the HIPEC was very safely in order to administer that. But some comment about that is that it is so aggressive to perform up to 3 surgical procedures on this patient. In the control group, the patient received 2 procedures, has the laparoscopy, the diagnostic laparoscopy at 18 months after the procedure. But the morbidity was acceptable on this trial. We had to evaluate if the laparoscopy at 18 months it is needed or not. I think that the Colorectal 2 could give some response about this issue. And the stages approach, like the Colorectal said, that the HIPEC staging happened, allow the patient referral from non-HIPEC center or perforated tumor referral to the HIPEC center. HIPEC T4 is a Spanish trial, and our objective was to evaluate the safety and efficacy of the reductive surgery for the T4 colon cancer, and the use of the HIPEC using metomycin C. Our primary endpoint on this trial, the trial was designed for this primary endpoint, was the local regional control disease at 3 years. As secondary endpoint, we have the safety, we have the disease-free survival, and overall survival. It was a multi-center randomized phase 3 trial. The sample size was 180 patients. We will decrease the peritoneal relapse from the local regional control from the 82% up to the 64% up to 82%. Sorry. And the center included was 17 centers belonging to the Spanish Bureau of Peritoneal Oncology and Surgery. This is the design of the HIPEC T4. The inclusion criteria was like the patient that I presented in my case. This is the T4 colon cancer, clinical T4 with N0 to 2. It is allowed up to N2 if we are going to remove all the lymph node during the surgery. It is not allowed the presence of any metastasis, only peritoneal metastasis, ovarian metastasis. It is not allowed to be included on this trial. The modified intention to treat population was 184 patients, It was randomized for surgery and adjuvant systemic chemo, or the experimental arm was surgery plus HIPEC with mitomycin C, 30 milligrams per square meter during 60 minutes. This is the recruitment of the HIPEC T4. These are the results. This is a very huge table, but I only want to say that the two groups are balanced in order to the possible risk factor to the peritoneal carcinomatosis has the allocation of the tumor, like the right column percentage. It was similar between the two groups. The definitive pathological state has the definitive T stage or N stage was similar between between both. The grade of differentiation, mucinous, inner ring, BRAF mutation, KRAS mutation was similar between the two groups. The quality of the surgery also was similar because the lymph node isolated was the same between the two groups. And also, it is important that the laparoscopic approach was higher on the HIPEC group. On the HIPEC did not impair the laparoscopic approach for this population. The primary endpoint was the local regional control rate, and we can see here that the HIPEC group have a higher local regional control rate than the comparator group. Our hazard ratio was 0.21, and the confidence interval was so wide, and we performed additional restricted mean survival for this patient. It was also significant the benefit for HIPEC at 24 months and the 36 months in the restricted mean survival analysis. This is the pattern of the relapse for the two groups, and you can see here that the statistically different was the relapse was in the control group on the peritoneum, focuses on the peritoneum, but the systemic relapse was not prevented by HIPEC. It was prevented the peritoneal relapse. This is the forest plot. You can see here that the subgroup of the PT4 or subgroup with adjuvant chemo, but sometimes it is the same group, were benefit by the use of HIPEC, more benefit for this subpopulation. In this exploratory analysis, we take only the patient with a definitive PT4 colon cancer. The use of HIPEC improved the local regional control rate in this special subpopulation. This is have been published. This is the study of the disease-free survival on this subgroup of the PT4. You can see here that there is a trend in order to benefit on the disease-free survival for this subgroup of the patient. We have to make a long-term analysis for this trial, and we are doing the long-term analysis on the HIPEC T4, and also we want to analyze what a specific subgroup will be the HIPEC more benefit. Secondary endpoint was the disease-free survival. It has been criticized that this trial did not show a benefit on this disease-free survival. It is true, but the trial was not designed to discover difference on the disease-free survival. However, we can see a trend in order to benefit for the disease-free survival, and we are going to expect for the long-term result for this trial. Obviously, there is no difference on the overall survival between the two groups. As I said before, this is very important in the setting of the prophylactic context. The morbidity. We can see here that the use of the mitomycin C, HIPEC with mitomycin C, did not increase the toxicity and did not increase the morbidity for the experimental group. In conclusion, we can see here that the HIPEC with mitomycin C associated with a very good surgery in locally advanced colorectal cancer improved the local regional control rate without increasing the morbidity. And this clinical benefit is created in a definitive PT4 subpopulation. Thank you so much.
Thank
That's
you.
fantastic. Thank you for that. I might kick off with a question to start with while people are adding their questions to the Q&A. Where do you think MSI status is going to fit into this in terms of stratifying these patients for future studies and the role of immunotherapy in all of this?
Yeah, I think that we had to look for this factor, this important factor in very subpopulation, because we have the NSI patient that could benefit with the PD-L1 inhibitors, and I think that maybe the surgery or maybe the adjuvant chemo could be avoided on this patient. Maybe we have to explore another point for this patient in order to define a high risk condition. Have the circulating tumor DNA could be a very good tool in order to define a high risk condition for patient in order to do a proactive treatment or aggressive treatment like HIPEC or neoadjuvant chemo. We have to define the population, I think.
There's one question from the chat. Sorry. There's one question from the chat. So in an unpublished data from our center, this is from Preeti Shiti, we found that young onset colorectal cancer and signet ring cell carcinoma also have high propensity for peritoneal metastasis. What is your opinion on that? Alvaro, you mentioned the biology of your cohort from the HIPEC T4 trial. Can you comment on that?
We have not found any relationship because the percentage of the signet ring was very low. I think that it was a very statistical reason or population reason. I agree with Preeti Shiti that our feeling with the patient with signet ring colon cancer, the prognosis is worse. The peritoneal relapse is more frequent for this patient.
And then there's another question from the chat regarding the surgical technique. I think it's also for Ignace and for everyone for us. So from Fernando Iglesia from Argentina, he's asking which technique do you use for the HIPEC, a Coliseum technique or a closed one? And if you have some experience in prophylactic treatment with the PPAC.
I don't have experience with PPAC on prophylactic setting. The technique in the trial was free for the different groups. We have to perform exploratory analysis about what is the benefit about close open that, but all the technique was allowed. The only requirement for this trial was the dose of the metomycin C at the time of the metomycin C, and not the technique. It was allowed open or closed technique. In my institution, we perform a semi-open Coliseum technique if we open the patient, but the most of the T4 colon cancer we perform it by laparoscopic approach, and we use the closed technique for that.
So can I ask you, you've shown us that the most profound effect is in the actual PT4 cancers. Both in your trial and also in the Foxtrot trial, about a quarter of patients were not PT4. So how can we reduce this in the future?
Well, this is a very good question, and we have discussed this issue. I say, for example, on the meeting in Bruce, it is very difficult for the radiologists to define the T4 because the inflammation or because the desmoplastic reaction around the tumor could confirm the limits of the T stage by radiology setting. There is some tools that CT by IV contrast, but MRI maybe or something like that. But the radiologists were very disappointed with the ability to discriminate between T3 or T4. Also, the the Foxtrot trial have the 24% of the low risk patient, but they include the high risk T3 patient on this trial. We have 30% of the overtreated patient, considered overtreated patient. We have 33%, but we only included the T4 colon cancer and not included the definitive T3 colon cancer has the Foxtrot. But I think that it is very disappointing the ability to different the T3 or T4. It is very difficult.
There's some more questions on the chat there. One question there is, do you think that HIPEC method of intraperitoneal chemotherapy could help treat only the truly PT4 cases and eliminate overtreatment?
Yes, I think that this could be a very good strategy. Maybe the stage HIPEC after pathological report. The problem is, but you are going to undergo the patient to 2 surgical procedures. You can delay adjuvant chemo, and also the patient will have attention about the primary surgery. This is the disadvantage. The advantage is that you are not going to overtreat the patient. You can see you can administer the HIPEC for the very selected patient. I think that we have to explore this condition.
And then the next 2 questions are both about the mitomycin protocol. Do you want to comment on why you picked the mitomycin protocol that you did in terms of duration and dose calculation?
Well, the HIPEC using mitomycin C, we use our protocol that we use during several years, and this is the low doses possible. This is the 30 milligram per square meter during 60 minutes only. We are on the prophylactic setting. It's not the treatment setting. We would like to reduce the morbidity, any morbidity for this patient, and to reduce the difficulty to adhere for this treatment for the different center, because this was a multi-center trial. And it is important that one only doses for mitomycin C during 60 minutes is easier than 3 consecutive doses during 90 minutes, in order to encourage to the other surgeon to include patients for this trial. But I think that the curve of the mitomycin C, the higher effect is the 40 minutes, 45 minutes after the administration. I think that 60 minutes could be enough in one only dose.
Great. There's quite a few questions on the chat. Do you consider that a CT4 tumor should be minimally invasive? I guess the question is about minimally invasive approach versus open surgery. And does that change, I guess, the equation for when we should do prophylactic HIPEC, now that there's the possibility of doing more minimally invasive approaches to HIPEC?
Well, I think that the T4 colon cancer could be managed by minimal invasive approach. This is very common in most of the center. Even for Europe, I think that the management for T4 colon cancer by laparoscopic approach is very feasible. But only a few cases with very gross infiltration, very extensive infiltration of a lot of organs could be not managed by laparoscopic approach. But the majority of the T4 colon cancer could be managed by laparoscopy, and the use of HIPEC is very feasible by laparoscopic approach. By the port of the laparoscopy is very easy, and don't increase don't increase the morbidity for this patient. We have shown that the laparoscopy is feasible, and we have shown more patients treated by laparoscopy with HIPEC on the experimental group than the control group.
There's a last question. Thank you so much for the nice questions. I also answered one by typing. So there's a question from a surgeon from Turkey. He says, a patient was performed colectomy with T4 1 year ago, and now he will be operated for incisional hernia. Do you see there any place for adding HIPEC 1 year as a prophylactic?
No, I don't advise this procedure because you will have attention for that. If you don't have a disease for this patient, I don't administer HIPEC for this patient. It's not indicated 1 year later.
I guess that leads on to maybe one last question from me. Do you think we should change practice based on this trial? So have you changed your practice for your T4 patients going forward based on the results of the trial?
Well, I think yes. This is my trial. I'm very happy with the result. We have seen that the results were better with the use of HIPEC. We have to know that it is difficult to combine the oncological community if we don't have the result of the disease-free survival for this patient. Only the local regional control or peritoneal-free survival is not, I think, is not enough for the oncology community. But I think that several local regional treatment has HIPEC, radiotherapy. The endpoint of the local regional control disease, it is a very good endpoint. It could be surrogated for the survival for this patient. But we had to wait for the long-term result. I showed that in some subgroup could be benefit on the disease-free survival. And we are working together with Peter Tanis and me. We are working together to find resolve to join in the Colorectal and the HIPEC in order to find which type of subgroup will be benefit for this approach. And I think that it could be very interesting. And also it could be interesting to join the neoadjuvant chemo and HIPEC for this patient. I think that this is our next project. It is to design a trial joining the both for this patient.
Thank you so much. Sit down and relax and listen to the presentation of our next speaker. As I said, I'm very happy, Niels, that you're with us tonight and you will share your thoughts on synchronous peritoneal colorectal metastasis.
Okay, thank you so much.
Well, thank you very much, Niels, for your kind introduction. Thank you for ESSO for inviting me to this webinar. And I was asked to tell you something about the treatment of synchronous peritoneal colorectal metastasis with cytoreductive surgery and HIPEC. And these are my conflicts of interest. And before I start with the case, I would like to give you some background information on this. For instance, about the incidence of colorectal peritoneal metastasis. What is the impact of this disease? And we studied that about 2 years ago in more than 7,000 colorectal cancer patients in the Netherlands. And what we did see is that at the time of the primary diagnosis of colorectal cancer, 5.7% of patients were already diagnosed with peritoneal metastasis. And this is the patients we are talking about today, those with synchronous peritoneal metastasis. These patients obviously need some sort of treatment. And then after initial curative treatment, another 5.5% of patients will also be diagnosed with peritoneal metastasis during follow-up. And these were the patients that hopefully in the future can be prevented thanks to studies as Alvaro has just shown us so nicely to us. So altogether, about 1 in 10 patients with colorectal cancer will eventually develop peritoneal metastasis. And today, again, I will talk to you about the treatment of these patients. And this is the case I would like to introduce to you. a 62-year-old female referred to us from another hospital, previously healthy, no history of any medical disease. She was asymptomatic, was found during screening. She had a positive FIT test, and during colonoscopy, a sigmoid tumor was found. The pathology of this tumor showed an adenocarcinoma, and a CT scan showed C-T4N0M0 sigmoid cancer. In the referring hospital, actually, the surgeons started the procedure by a laparoscopic sigmoid resection. At least that was intended. But soon after they entered the peritoneal cavity, they saw what they said, a few peritoneal deposits. They stopped the procedure and decided to refer the patients to us because these peritoneal deposits appear to be peritoneal metastases. So she was referred to our hospital for CRS and HIPEC, and that is the basis of the principal treatment in the Netherlands since this trial that was already published 20 years ago in the Journal of Clinical Oncology from Amsterdam. It randomized patients between palliative systemic treatment and the experimental treatment at that time being CRS and HIPEC. And here you can see immediately the survival curves of these two groups. And of course, this study has been published already 20 years ago, but still is one of the only ones that has addressed this question. Interestingly, again, is to see the survival of the HIPEC group being 22.3 months. And at that time, it was a breakthrough because it was for the first time that something could be offered. But we thought that maybe we should do better. And doing better is most of the time just having a better selection of your patients. How can you predict which patients will benefit from CRS and HIPEC and which patients will not? And well, I presented the case to you, and if this was a live audience, I would ask the audience right now, what would you like to know more for this patient, from this patient, I should say, before you should decide for CRS and HIPEC? But as you're all muted, I'll just ask, for instance, Niels, our moderator of today, what additional details do you think should be needed from this patient before we proceed to decide for HIPEC?
So you put me under pressure now, but one of the things I would like to ask you if there are any extraperitoneal metastases.
No, it was an M0 tumor. So that was already ruled out by the CT scan.
So the other thing is, does histology matter here?
Yes, probably is. And well, let's go straight to that point, because it was also asked in the chat to Alvaro in the previous session. Indeed, pathology is very important, because the only thing we know right now is that this patient is suffering from an adenocarcinoma. But as was also already discussed in the previous discussion, is that we now have immunotherapy for those patients that are diagnosed with microsatellite unstable tumors. We are not completely sure yet whether this is important for patients with peritoneal metastases as well, but it's at least something to take into consideration. So that's one important thing. We should know of our patients, what is the MSS status of these tumors. Another thing also addressed previously is this very typical cells that can be found in colorectal cancer. These are signet ring cells, of course. And these patients with signet ring cell histology have a higher chance of developing peritoneal metastases. So they are quite often in groups with peritoneal metastases. And not only that, they respond very poorly to CRS and HIPEC. We published that a few years ago in our own cohort. Since we were very much disappointed by some of our treatments, we found out that most of the time, those were the patients with signet ring colorectal cancer. So for now, at least in the Netherlands, that is a relative contraindication for CRS and HIPEC. And some have even gone further in their biological characterizations of tumor, for instance, BRAF mutations. We do know that patients with a BRAF mutation also have a worse prognosis than those who have not. but at least in our hospital for now, we do not take that into account yet. But it's a very interesting development. So this patient appeared to have a moderately differentiated microsatellite stable non-signet ring cell adenocarcinoma, and therefore, for this point, at least, she was suitable for CRS and HIPEC. Another thing we would like to know, well, the referring surgeon spoke about a few peritoneal deposits. And well, I have to say, what some call a few, call other persons a lot. So we need not to adhere to these qualitative impressions of the amount of peritoneal metastases, but we should quantify it. And of course, we do so with the peritoneal cancer index by dividing the peritoneal cavity into 13 regions and giving 1, 2, or 3 points to the region depending on the amount of tumor, or 0 if there's no tumor to be found. And we do so because there is a linear relationship of the PCI with survival in these patients, as we all know. And at least in the Netherlands, we have had the appointment that we should do CRS and HIPEC only in those patients that have a PCI of maximum 20. And compared to other countries, that might even be a little bit high. I have heard of lower maximum PCIs around the world, but it's something that should be investigated into your own context of treatments. Another thing that should be considered is whether we could completely resect the peritoneal metastasis. Here you can see the graphs from one of the studies from the Netherlands, where you can see that if you're an R1 resection or microscopic radical resection, then you have good results. But if you have to leave tumor behind, your results drop considerably. So right now, we consider only those patients suitable for CRS and HIPEC that you can achieve a microscopic complete CRS during surgery. So that is really important to consider, because sometimes you get a referral of these kinds of patients with a PCI of only 12. Here you can clearly see these little spots. Maybe they count them as 1. Maybe they say it's only the small intestine that is involved. But I guess we can all agree very soon that this is not, we are not capable of removing these hundreds or even thousands of metastases if they cover the complete intestine. So not only the height of the PCI is important, but also whether or not we can resect them. So how should we assess peritoneal disease? The important question, what is the PCI and can we resect it? Well, in oncology, we normally count a lot on imaging. CT scans, PET scans, ultrasounds are all very familiar to us, but unfortunately, these investigations do usually not show very reliably the amount of peritoneal metastasis. And that is why currently in most countries, I guess, a diagnostic laparoscopy prior to CRS and HIPEC is considered to be the gold standard. And although it's a very helpful tool, it also comes with problems. If a patient has been operated before, you get these adhesions, and it's often very difficult to investigate the diaphragms or the small pelvis. And this is another problem that I'm showing you that can occur after diagnostic laparoscopy, being a port-side metastasis into the abdominal wall, which can be very troublesome. So there are now alternatives to diagnostic laparoscopy that are being investigated. For instance, the diffusion-weighted whole body MRI. Here you can see an example. And I've been told by our radiologists that are really keen on this procedure that it's much more easy to detect these nodules than on a conventional CT scan or an MRI scan. And Max Lahey, a radiologist from Amsterdam, is currently running the DISCO trial, randomizing patients to undergo either a DLS or an MRI to investigate which of both measures will be the best to detect the amount of disease. And we are kind of hopeful that that will be MRI, because that would be a better and less harmful investigation for the patients. So we did actually diagnose laparoscopy in this particular patient that was referred to us. And here you can see what we did see. Indeed, quite some lesions actually. Here on the right diaphragm, you can see that the liver is clean, or almost clean at least. and that it's very typical in peritoneal metastases that these lesions accumulate underneath the right diaphragm. And in this particular patient, we scored the PCI in total of 11. So the right upper quadrant and also in the small pelvis. And fortunately, the small bowel was completely spared by this disease. So this patient was now referred to us with a PCI of 11, resectable disease, and we accepted her for CRS and HIPEC. But then the discussion goes on, because if we decide to do CRS and HIPEC, we should also think about some sort of neoadjuvant systemic treatment. Is that of value to these patients? We don't actually know. And if we do not think about neoadjuvant systemic treatment, we might think of adjuvant systemic treatment, or why not combine the two? Or another option is to leave both treatments behind. Very important discussion, I think. Quite some studies going on, but currently the data from randomized control trials won't tell us any answers, because literally no data in literature, at least not from randomized control trials, that we can depend on for this discussion. That's why in the Netherlands we did a cohort study published in 2020, in which we investigated patients that either got adjuvant systemic chemotherapy or active surveillance only, so without any systemic treatment. So they were treated by CRS and HIPEC only. And these are the results. On the blue line is the active surveillance group, so no adjuvant chemotherapy, and the orange line got systemic therapy. And the overall survival is quite remarkably different, being 24 versus 39 months. But as these Kaplan-Meier curves are separating very early after start of a registration, there is a high risk of residual bias, meaning that maybe we did not give adjuvant chemotherapy to those patients that were in a bad condition after cytoreductive surgery and HIPEC. And this might in fact be the reason why they have a shorter survival. This is another study investigating quite the same topic, also from the European Journal of Surgical Oncology. It's from Belgium, and there they had, Kaplan-Meier curves that looked pretty much the same. But interestingly, in this case, the patients that received chemotherapy did worse than those who did not receive chemotherapy. So completely opposite findings than our study. Again, a retrospective analysis, so there might be a lot of bias into this study, but it is interesting that in two neighboring countries, the strategy is the same, but the outcome is completely different. So as I said, this is an ongoing discussion, and in the Netherlands, as you might have heard before, we are now performing the CARO6 randomized control trial, randomizing neoadjuvant and adjuvant systemic chemotherapy versus no chemotherapy at all. So the discussion continues. If you have accepted patients for CRS and HIPEC, and if you decided on your systemic treatment, the next question is, which HIPEC regimen should you use? I told you before, 2003, we had this regimen from the Netherlands. It's also sometimes called the Dutch protocol for that reason. HIPEC included mitomycin C, and that is in a high dosage, it's 35 milligrams per square meter with a maximum of 2 square meters. We heated it to 41 to 42 degrees, and we did so for 90 minutes in total. But another very popular HIPEC regimen was a French regimen consisting of oxaliplatin, also to 41 to 42 degrees, but much shorter, 30 minutes. And these are just two well-known schedules, but if you look into the literature, you'll literally find tens of different regimens that you can use. And well, probably they're all good, but some are maybe better, and one probably is the best. So which one to choose? No randomized data again, but fortunately we had a group of colleagues that took the effort to make a consensus, an international expert consensus on this topic, and they are currently publishing their results. If you'd like to see their presentation, it's still on oncostream.com, still available to watch it, and very informatics. also for ovarian, mesothelioma, and gastric cancer. So if you're interested in this topic, definitely a must watch if you ask me. Very recently, the regimen for colorectal cancer was published by this expert group, and well, consensus was reached to use the Dutch protocol, mitomycin C, 42 degrees, 90 minutes. And for those of you who are not very familiar with HIPEC yet, because I know there are a lot of experts in the audience, but also some people that might be interested to start it. This is the way we do it. We give it in 3 different dosages, as you can see here. We use a certified heating machine. We use 2 inflow catheters and 3 outflow catheters. And we use the Colosseum technique. We are now filling it up. This fluid should come to the level of the skin. And so you can easily see this is an open technique, but the expert consensus agreed that a closed technique can be used as well. So again, we accepted this patient in our hospital for CRS and HIPEC, and we did so with the current clinical pathway. Of course, this patient had to be fit for major surgery. Age for us is not a very important topic. It should be a healthy and fit patient, and age doesn't really matter. No systemic metastasis, no signet ring cell histology, a maximum PCI of 20, and we have to be sure that a complete CRS is possible. So again, we accepted her because she hit all the boxes. But then this lady had some questions for us as well. Not only we for her, but she to us as well. She asked us, well, what is actually the long-term outcome of this procedure that you're trying to do to me? And this is what we investigated for the Netherlands in another population-based study. We looked for treatment strategies and prognosis of this treatment. And as you can see here, patients after CRS and HIPEC survived for about 36 months. The red dots are the synchronous tumors, and the blue ones are the metachronous tumors. So about 36 months survival, which this patient clearly found acceptable. Another more intriguing question was, she asked me, am I at the right place for a safe procedure? And well, fortunately, we also had some data on that. This is under review, so it's very new. It's our Dutch HIPEC quality registry, in which we register every single CRS and HIPEC that is performed in 6 out of 8 hospitals in the Netherlands. And we included already 588 patients, and we collected here the severe postoperative complications, being claving adeno larger or equal to 4. In our peritoneal metastases, we had about 1% of those complications, and the mortality was even less than 1%. In PMP, it was slightly higher, but again, the patient was reassured that she could have a safe procedure. But we ourselves took it a little step further, and we decided to look at each individual hospital in the Netherlands, 6 different hospitals. I clearly don't know which is mine, but there are some intriguing results. For instance, there is a large variation in severe complications, varying from 37 to 14%. Also, the formation of an ostomy during surgery is clearly very different, ranging from 18 to 53%. So big variation in a small country as the Netherlands. And to me, there was an eye-opener. And really, we do believe that there is room for improvement if we start comparing these data with each other. And we are very willing to do so in our Dutch peritoneal oncology group. We are trying to learn from each other. So very happy to be part of that. And of course, very happy to share these results with you during this webinar. Final remark, if you are interested in CRS and HIPEC, please feel free to join us from 14th to 16th of March. Unfortunately, not anymore in Hamburg because that venue has been closed, but in Hanover, I'm sure that will be a very good alternative. I'll thank you very much for your attention.
Thank you for an excellent talk again. Really great. There's just one question on the chat so far, which again is just relating to what your protocol is for delivering the mitomycin C during the HIPEC.
My protocol again for mitomycin C?
It says, how do you deliver the mitomycin C during the HIPEC? I guess they're asking, do you use an open or a closed technique, or what your preferences are for delivery of HIPEC?
Yeah, well, we personally prefer mitomycin C, 3 dosages in 90 minutes, open technique. But again, the expert consensus for that included many centers around the world. They have not decided which one should be the best. So both open and closed technique, I think, are both good techniques. I do believe that mitomycin C is a better drug than oxaliplatin. We have shown that in our organoids work in the lab that these organoids are usually quite resistant to oxaliplatin. They're also resistant to mitomycin C, so there's a clear challenge for us as scientists in HIPEC to look for better drugs to kill these cells. But for now, I think mitomycin C is the best drug to use.
Maybe before there are more questions coming on the chat, I have a question for you, Ignas. Thank you for the very nice presentation. What is, from your point of view, the way to the future? Are we now happy to have a consensus to use the same regimen, which I think is a key milestone in our development? Or what is the future from your point of view? Where do we go? Do we go for more basic research, for more lab work? Are we heading to individualized HIPEC regimens according to the tumor of the patients? What is your view on that?
Well, my view is that that these currently used drugs, both mitomycin C and oxaliplatin, really are not the best drugs to be used. I'm not sure if we have those drugs already that are very effective against peritoneal metastases, but if not, we should surely develop them. And the more we know, the more we learn about these peritoneal metastases, the more we know about the way they can be treated. And I know now that in some labs around the world, they have now found some very active drugs specifically against peritoneal metastases. And I really hope we can bring them to the clinic very soon, because there's a clear need for better drugs. So for now, I think it's important to adhere to one protocol, but for the future, we definitely need better and more effective drugs.
So, Niels, can I ask you, when we go back to the case, so the doctors in the other hospital clearly did most things right. They stopped the procedure and referred the patient to your center. But probably you also encounter quite often patients who had undergone the sigmoid resection already.
Unfortunately, yes, because we really try to inform our colleagues in the region that it's highly preferable to stop the procedure when you find peritoneal metastasis. If you go on with surgery, you will cause a very pro-inflammatory response into the peritoneal cavity, which the peritoneal metastasis will probably benefit from. You have scar tissue. So yes, we really advocate them to stop. But yes, you're right. Sometimes they proceed and they will see the pathology report afterwards and send them to us. And then it's always a very difficult question whether or not you should go for adjuvant HIPEC in such cases. Clearly, that's something that needs to be investigated further. But if the case was not complicated, if it was a laparoscopic procedure, we tend to do an adjuvant HIPEC. We remove the omentum. If the patient is postmenopausal, we definitely pay attention to the ovaries, if they should be removed or not. So we are keen to do some additional treatment if it's possible.
And what do you do with the anastomosis in those cases?
Very good question. Well, previously, we took them out by protocol. And we had learned so from your predecessor from Amsterdam to remove every anastomosis that has been constructed before. But gradually, we have been a little bit less aggressive in that respect. We inspect it very thoroughly. And if there is really no sign of peritoneal dissemination, sometimes we decide to leave especially the low rectal anastomosis intact, because if not, you'll end up with an ostomy or a high-risk anastomosis. It's different, of course, with small bowel anastomosis. We are much more liberal in removing those in secondary surgery. But it's always a very difficult decision. I don't know, Niels, do you still do did by protocol remove all anastomosis, or do you also take a closer look?
We do the same as you are doing, and as you refer to the DISCO study, we're keen on MRI as well, and we're currently looking at those patients who had an MRI in a previous anastomosis, if we can see something on the MRI and related to what we did at surgery. Maybe some questions of the chat.
Yes, there are some questions now popping up. That one I think is interesting regarding the signet ring cell cancer. So the question comes from Lionel Munoz Sagredo, and he's asking, wouldn't it be worth to look for other agents for HIPEC and separatiles instead of dooming it to be a counterindication for serous and HIPEC? And I would like also to ask you, do you really see it a counterindication for serous and HIPEC, the signet ring cells?
Well, as I told you, we have very, very disappointing results. Because of the time, I couldn't include the graphs, but we did not have survivors more than 28 months after serous and HIPEC in those patients with signet ring cell histology. So, to be honest, it is not an absolute contraindication. So if this young patient with a PCI of less than 10 will proceed. But if you are in doubt, if the PCI is already high, if the patient is in a condition that you're in doubt whether you can do serous and HIPEC, and if this patient then also presents with signet ring cell histology, then probably the combination of those factors would be better not to treat them with serous and HIPEC. But it's under debate, but at least in our hands, serous and HIPEC in signet ring cell histology comes with very bad results.
Thank you so much. And there's another question. I think it targets the Cairo trial in the Netherlands from Selman Sokman. How did you reach to a conclusion and observation to design your clinical oncological studies not to give neoadjuvant and or adjuvant chemotherapy for colorectal peritoneal metastasis patients?
Well, we looked for all the available evidence that was in the literature. As I showed you, there are no randomized controlled trials to guide this. So, in fact, there is no science at all showing that you should give these patients systemic chemotherapy. You might do so for selecting patients. If you give these patients chemo and they progress, you won't do serous and HIPEC. If they don't progress, you do serous and HIPEC. And then, of course, in the patients you did serous and HIPEC, you'll have better results after selection. So, but if this is a sensible way to do so, it's an open question to me. Our hypothesis, of course, is that perioperative chemotherapy will improve survival. So our trial is designed to show that. So we expect an adjuvant treatment benefit, but we're not sure yet. So that's why we're doing this trial. And our medical oncologists actually completely agreed with this. They actually were one of the biggest proponents to do so, because they said they are not sure at all whether this should be done or not.
Maybe another. Sorry, Helen.
It's another question on the chat there from Wenalito Clapano. What are your thoughts about intraperitoneal chemotherapy as neoadjuvant for patients with high PCI? Do you think it's a practical approach? I guess in particular, for those patients who are planned for serous and HIPEC, and then when you go to do the serous and HIPEC and their PCI is actually higher than estimated at the laparoscopy, do you tend to go ahead and give those patients the HIPEC, or what is your approach there?
I believe the question was in the first time whether we give IP chemotherapy as some sort of neoadjuvant strategy. And to tell you, we do not do so at this moment of time, but we are clearly thinking of it. It's actually the idea of the next trial after Cairo 6 will be finished, to give these patients intraperitoneal chemotherapy prior to serous and HIPEC. And that is based on the findings of the INTERACT study that was performed by colleagues of mine in the Netherlands. that gave IP chemotherapy by a Porta-Cut catheter for 12 weeks in a row, irinotecan based, and well, at least to my surprise, with very, very good response of peritoneal metastases. So this was done in a palliative setting, and of the 12 patients that were included, or 18 patients, I believe, 4 patients in the end could actually go on for CRS and HIPEC, whereas they could not by the start of the trial. So it's a very interesting strategy, I would say, something that should be investigated. Whether you do so by PIPEC or by an IP catheter is another interesting topic, I would say. But yes, my answer to that question would clearly be that it is a very interesting strategy. The other question about progression during chemotherapy, if a patient progresses during chemotherapy, I do think that's another bad indicator for outcome. Aggressive biology of the tumor. So we tend, in the CARO6 trial, if they progress systemically or if they progress dramatically intraperitoneally during systemic treatment, we do not offer them CRS and HIPEC.
Are there any more questions from the panel?
I guess not.
Okay. So I'd like to thank both of our speakers. It's fantastic to have 2 real-world experts and with cutting-edge, groundbreaking trials here to talk to us this evening. So thank you all for coming and for attending, and thanks to all of our attendees for joining the webinar this evening. The talks will be available afterwards, as mentioned. Thanks again, everybody.